And it's just a huge honor for me today to be podcast interviewing Dr. Careen Young, DDS, MSD, is originally from Toronto, Canada, where she received her dental degree from the University of Toronto. Afterwards, she completed a McGill University general practice residency and then a master's degree and a specialty degree in prosthodontics at the University of Washington in Seattle. In the early years following graduation, she taught briefly at the University of Washington, UCLA, USC dental schools. In addition, she has lectured at various dental organizations on the subjects of aesthetic dentistry, implants, and prosthodontics. She remains at the forefront of dentistry and has maintained a private practice in Beverly Hills, I assume that's 90210, for over 20 years. Dr. Young was awarded the Lucy Hobbs 2013 Icon in the Industry Award, which honors exemplary women in the dental community. That same year, she was elected by her peers to participate in the prestigious Pierre Fauchard Academy, an international dental service organization whose consistent focus is on integrity, ethics, and professionalism while providing excellence in treatment, education, and leadership, both personally and within the dental community. Her practice has been chosen, among others, to be included among the Los Angeles Magazine Top Dentists from 2014 to 2019. Dr. Young is an active in 7 professional organizations, including the American, Californian, Los Angeles Dental Associations, the Academy of Fixed Prosthodontics, Academy of Osseointegration, Newport Harbor Academy, and the Beverly Hills Academy of Dentistry. Dr. Young has also served 2 terms on the board of directors of the Beverly Hills Dental Academy. She was a guest editor of the California Dental Association Journal when they had an issue dedicated to porcelain veneers. Dr. Young's philosophy in dentistry is biomimetic,
so mimicking biology.
Biomimetic.
Mm-hmm.
Interdisciplinary and facially generated approach geared at providing patients a natural and healthy dentition and smile. Our goal is to improve a patient's aesthetics, function, and health so that patients may feel confident about their smile and forget about past traumas they have endured. Congratulations on all you've done, but I wanted to jump right on the cosmetics because I notice, America's a melting pot, but when you go around the world, like Europeans think Americans' teeth are too white. They look clownish. But then when you go to the Middle East, oh my God, the Middle East, when you're wearing a veil and the only thing that shows your teeth, they're Clorox white. I mean, the Middle East, the teeth of the Middle East, they go for the whitest shade possible. And I remember going back to Ivoclar during the cosmetic revolution when that was going on strong. Williams Ivoclar had to make lighter shades of bleach. I mean, their whitest composite wasn't even white enough. So in Beverly Hills, where you have people from every corner of the world, do you see some countries, some origins of people wanting whiter teeth, and then some patients, when they say natural, they don't want it to stand out and they want it to look more normal? Or is that how do you gauge that?
I gauge that individually with each patient. And I agree with you in Los Angeles and the United States, largely people would like whiter teeth. I think they're selling more and more whitening gel, bleaching gel in Europe. When I moved from Seattle, I had a lot of A2, A3, and I got down to Beverly Hills and I had to donate it. And now largely we are mostly buying A1. A1 is my more natural, darker shade, A1, some B1, and then some patients like lighter than that. But my more senior patients are cognizant of not wanting teeth that are too white because then they're afraid it's going to look fake 10 years from now. And so I find actually more the younger set of patients, the younger the patient, the whiter they go. And millennials certainly want very, very white off the Vita chart for sure. And if we head to my 30s and 40s and 50s, then they might be OM1, 1M1, something like that. And A1 would probably be the darkest that they would go. And then when I'm more senior patients, they would probably go no lighter than A1. And they prefer to say something more conservative, just because they don't want to be 80 years old and look like they have very, very white teeth. But I always reassure them it also has to do with the shape and opening the incisal embrasures.
I loved you on the cover of incisal edge when you were the Lucy Hobbs icon in the Industry Award, and that is just a fabulous picture of you on the cover. To everyone who doesn't know who Lucy Hobbs is and what that award is, what did that mean to you?
You know, it was just such an honor to be awarded that and anything. And I just felt like I have to do as much as possible to help my profession, my colleagues, because I had big shoes to fill and to live up to. And it was just a huge honor to be recognized in any shape or form.
And and what do you think of Lucy Hobbs? I mean, to people, Lucy Hobbs Taylor was an American school teacher and a dentist known for being the first woman to graduate from dental school. She was originally denied admittance to the Eclectic Medical College in Cincinnati, Ohio, due to her gender. She was born in 1883 and died in 1910 in Lawrence, Kansas. So she started out. She was born in New York, and she was smart enough to make it all the way to Kansas, where I'm from. What a great move for Lucy to move from New York to Kansas. But what does Lucy Hobbs mean to you?
I think it's remarkable that even back then, there was a woman who was able to get accepted into dental school and become a dentist. And I think it took a while, but I think there's far more women in dentistry now. And at the time when I was in dental school, I think maybe it would be 35%. When I went through my PROS program, I was the third woman, only the third woman who was accepted into that program in 25 years. And now there are far more women in prosthodontics. I used to attend prosthodontic conferences in Chicago, and I would stand at the back of the room, and they would literally be all bald or white heads and predominantly male. And I think it's really come a long way. The profession's really come a long way. There's far more women in all specialties. There's far more women that are dentists, and also multicultural. So I think dentistry has really come a long way.
And I wonder why Benko. They've always been into the humanitarian stuff. I mean, he's got the Lucy Hobbs Project. He's got the 43 the top influential dentists regularly, then the ones under 40. It's pretty. I think it's pretty neat how Benko does that. Why do you think they're into that?
I think they're very charitable, and I really appreciate companies, especially large companies, who can use their position and be influential and also be charitable and be giving back in some way. And they also had said that they recognized that often in families that it was the woman who was making the decisions, or they would be in the position where they are the ones who are responding to the marketing and making the decision for the family. So I think that they were recognizing that the decision makers often were the women, and there was an increase in women in the profession.
And then Pierre Fichard actually started dentistry, and you're involved with the Pierre Fichard too. When I lectured in Paris, France, I was so excited because I was going to go to the Pierre Fichard Academy, and I went there, had 3 of my 4 boys with me, and we did the tall tower thing, and then we went to the Eiffel Tower, and then we went to the Pierre Fichard Academy, and it was closed down for remodeling. And I'm like, oh my God, I'm gonna have to come all the way back to Paris just to get in there. But what would you say to someone listening to you right now that says they want to join the Pierre Fichard Academy? What would you say? Why did you do it? Why are you involved with it? Why is why? I mean, I'm sure you have not much free time on your hands, so why would this be a priority?
You know, when I was at the Lucy Hobbs Project and one of their events, there were so many different women who were active in the field of dentistry in one shape or form, and they had different charitable causes, some nonprofit, some were in private practice. And so just being recognized by Pierre Fichard Academy, sometimes some of those projects can receive some funding that may help their situation.
Nice. I don't want to get too controversial, but it is Dentistry Uncensored. You've lived in, you were born and raised in Toronto, and you went to school up there. You got your BSc and DDS from University of Toronto, Canada, and now then you got your MSD at University of Washington. How do you think of, how is Canada different than America, do you think, in dentistry? And more importantly, now in the middle of this pandemic, do you think that I mean, the numbers in Canada don't look too good, but it's very interesting when you see, when people say we have the best healthcare system in the world. It's like, well, you've never lived in the 20 other rich countries that have socialized medicine. It's so controversial. I mean, when I'm in Canada, they all love it. When you come to America, all the people over 65, they love Medicare. Well, that's socialized medicine. All the poor people like Medicaid. It's just that middle class, that working class that says, no, I don't want socialized medicine. I don't want big government. I don't want any of that stuff. But this pandemic is showing kind of some weak spots in the healthcare system. Do you think the healthcare system in Canada is better equipped for a pandemic like this than how you see it in Southern Cal?
Well, I have to make some clarifications here. So I don't know how the healthcare system is going to impact the treatment for patients who are affected by COVID, and how it's affecting the pandemic. However, dentistry is not socialized in Toronto, at least. So it may be a different thing based on different cities and provinces. But in Toronto, there's actually very little influence from insurance, whereas Los Angeles tends to be very insurance-based. And in terms of being socialized, having socialized medicine in Canada, I have to say that it's been pretty frustrating that when my mother needs appointments, and whether it's something for her ear or anything at all, you go see one physician, you book an appointment, you might be seen in 2 weeks, and then you're referred to a specialist, and then it might be another month later, and then, or you may have to be on the wait list for another 6 weeks, and then things have to be approved. So it actually, I actually say, from hearing what my cousin says and my mother, it sounds like it delays their treatment. So it's nice to have everything paid for, but it may delay the accessibility. And then there's the filtering process before you are accepted for treatment. Whereas when my mother came to visit, there's one time she came for a visit for 8 days, and literally I had her ride the elevator in my building. She saw the internist, then went to see the OB-GYN. We went up the street for a mammogram, and then had another appointment. I can't remember what it was. So the accessibility was much easier when it was fee for service. And then in terms of dentistry, as I mentioned here, there's a lot of insurance, and in Toronto, they tend to be very fee for service oriented.
So during this pandemic, when when they always say rock bottom is the best foundation. I mean, there's nothing better than, if you can't quit drinking, to get arrested and go to jail and lose your job and get divorced, and you're thinking, okay, this drink is not working for me. I think I'm going to quit doing that. And I feel like America's hit a rock bottom. I mean, we had we've had multiple bubbles. I graduated from high school in 80. I graduated from dental school. 80 was the worst economy I'd seen before now. And then I graduated in dental school in 87, and that was Black Monday. And then Y2K bust at 2000, Lehman's Day 2009. And now we're having, it was a pre-bubble, at least a year before. I mean, Warren Buffett quit buying any stocks a year before this pandemic. And then the pandemic, so you had a bubble in the stocks and bonds and equities. You had the pandemic, and then that set off the obvious issues of inequality and racism. And I always feel that, I always feel like, the year started out, 2020. I'm like, oh, okay, 2020, I'm going to get a filling on tooth number 3. And then it turned out to be a root canal, buildup and crown. And then the endodontist broke the file off, and then they had to extract it. No, I'm just the analogy for the year. But whenever I've seen like 9/11, when afterwards everything rearranged differently. And there's no way in the world after all this mess that we're not going to rearrange differently. So it wouldn't surprise me if there were major changes in healthcare. But a lot of dentists right now are thinking, you know what, during this pandemic and all this stuff, I think this is the best time to just drop insurance and go fee for service and all that. But then you say that you use a lot of fee for service in Canada, but I would think in Beverly Hills, like the richest, nicest area, people would just pay you in Benjamins and tell you to keep the change. I mean, it'd just be, so if the rich people in Beverly Hills are insurance driven, do you think dropping insurance in the middle of a pandemic is a brave new world order idea, or do you think it's foolish?
So I think Los Angeles in general is very insurance based. My practice happens to be fee for service. And if I was giving any advice to any dental practice, I think there are a number of different consultants, and I can help refer someone to someone, but there are a number of different consultants and management consultant companies that will advise you how to go about doing it. And it would involve taking an analysis of what insurance companies are supporting your practice and to what percentages, and then involve writing a letter to your patients, but before sending out the letters, actually personally calling the patients and going over it with them. I firmly believe that the best thing is just to educate your patient about all of their treatment options, and what treatment they need is based on what their real needs are and what treatment options they really have and the pros and cons. And their decision should be based on that first. And then depending on what they want, what the patient wants, not what we want, then try and help them find a way to work out the financial aspect of it. But I always, if I was giving some advice to some of my colleagues or junior colleagues, it would be not to treatment plan based on what you think the patient's wallet is, because even if I had a patient with more constricted means, and if I'm doing an extraction, I might say, you know, when we take out a tooth, the best thing would be to clean out that socket and place a bone graft. But if you're on a tighter budget and you need me to omit something, that would be one step, but that would be something I would prefer to have in my own mouth. And I have to say 8, 9 times out of 10, a patient would prefer to have the best treatment.
What, 8 out of 10?
8, 9 times out of 10.
Yeah, I think that is one of the hardest skills, because I've seen in my backyard where an older guy who did a lot of big cases sold a practice to a young kid, and they had the skills. They could do the dentistry, but they couldn't sell the cases. And they'd buy like an office doing, $1 million a year, and the next year after they had it, it went to 600. And there's presenting a case is almost as technically accomplishment as doing the root canal or doing the crown. Have you noticed that you present and succeed at presenting much larger cases now than you did 10 years ago?
I have to say yes. And sometimes it's not just us presenting. It's also when we speak to a patient, sometimes it's good to look a little older, but also we have to have the confidence and we have to present ourselves in a confident fashion, but we have to hear what the patient is hearing from us. So when we're speaking to the patients, this is something I train my staff as well. When you're saying something to a patient, how is your patient interpreting what you're saying? And I think a bad way of presenting things to a patient is just printing it up on paper and just sending it to them. I think we need to educate the patient about what's in their mouth, what is the situation, what is the problem, and show them their x-rays, show them their photos, and then tell them the different options and the pros and cons. And John Coyce always said this. I remember from John Coyce's lectures, he was one of my mentors. He said, patients will not buy treatment for problems they don't think they have. And that's brilliant. It's so true. So if a patient doesn't agree that they have a problem and doesn't think they have a problem, they're not going to accept treatment.
The thing I learned the most from John Coyce is before he seats any crown, he sprays Windex inside the crown.
I didn't hear about that one.
It's my joke. He's Greek. And remember my big fat Greek wedding
Okay, yes.
where that person was spraying the Windex on everything?
Yeah, and plastic, keeping plastic all over everything.
Oh my God! I broke his. He laughed so hard his rib broke when I told him that. You talk about. I'm going to read a paragraph from you. It says utilizing an interdisciplinary biomimetic and facially generated approach to dentistry to provide all patients with a natural and healthy result to restore their health, function, and cosmetics to give patients back their confidence. And when you talk about interdisciplinary biomimetic and facially generated approach, I really want to start with that whole sentence and break it down. When you talk about interdisciplinary, when you go back to 1900, healthcare was 1% of the economy, and by the end of the century 2000, it was 14%. Now we're 20 years into the new one, and so we're a fifth way, and it's already at 17%. The United States has 40,000 different healthcare journals. When I got out of school, there were only 9 specialties. Now, 32 years later, there's 12 specialties. Yet I keep hearing these young kids, and they're headed back to 1900. They come out of school and they go, I want to learn pediatric dentistry, silver diamine fluoride, endo, implants, Invisalign. I want to snore guards and this and that. And I'm like, really? You're going back to 1900 and one doctor's going to pull your tooth, deliver your baby, and amputate your foot? I mean, I just don't see it coming. With the overwhelming evidence that we're moving to a specialized world for the last 120 years, all the countries realize, I mean, like I tell people, my eye doctor tells me that there's eye doctors that only do glaucoma for diabetes. There's eye doctors who only do retinal detachment. I mean, you think just an eye, one person might be able to do an eye, and there's no way one person can do an eye. So what would you coach these young kids? Because you got to remember, our viewers, 25% are still in dental kindergarten school, and the rest are all under 30. So they're looking up to you as a leader, and they got their eyes set on just learning everything because they think they're going to keep it all in house. Maybe they're from the Midwest, and they like the ranch where you have your own beef and your own vegetables, and you do everything yourself. What would you tell some kid who says, I don't want to refer anything. I want to learn how to do it all? What would you say to that kid?
Well, Howard, I think here's the situation. I think that, every dentist is going to have a different comfort zone. And I think it's very important for each dentist, and every dentist at a different stage in their career is going to have a different comfort zone. And you could have one dentist who's 5 years out compared with another dentist who's 5 years out. And they may be attempting more things than someone who's 10 years out. And every single dentist is different. Number one, I think you can't do well in dentistry unless you love it, unless you're passionate about it, because you're going to work very, very hard. And no matter whether you're an attorney, physician, or a dentist, you're not going to do well unless you absolutely love it and are passionate about it. And you should just keep learning and find that part that makes it interesting for you. In terms of how well you're going to do, if you're doing something for the first time and you're pulling things out and you hardly ever do it, it might actually take you more time, invest you more time, effort, expense, and you might lose a patient if you are doing it so sporadically. But I'm not discouraging anyone. And I do encourage everyone, hone your skills on whatever you're doing. And then you might add something, a new skill. And it would be great to form a relationship with a number of different specialists, whether it's perio, ortho, or pros. And not everyone is going to steal your patients. We just want to form a relationship with you. So I have a relationship with a lot of different general dentists, and whatever they want to do is okay with me. And I'm here in a supportive role. If they need help, I'm happy to help quarterback it or educate. And it does take time to take a lot of extra courses and learn it. And you just don't want to run into a problem and then get sued or lose a patient and lose a whole family. So I just leave it to each dentist. And sometimes I'll get a referral and the patient might just need some bonding on tooth number 8 or a single crown here and there. And I generally tell them, you can go back to your dentist for this. And I'll call the dentist and say, would you like to have this patient back? And this is what I found that they need. I inform the patient that you've noticed it too. And this was just on a back burner. And I leave it up to that dentist. And they sometimes will say, you know what, why don't you just finish off this patient, take care of everything? And sometimes they'll say, oh, thank you. And they'll have the patient back for the bleaching and for the posterior crowns. So I find that each dentist is different. And in terms of their comfort zone, and some will attempt a full mouth reconstruction, and some just want to do veneers, and some just want to do their single crowns, 3 or 4 unit bridges, and they don't want to do dentures. And for me, that's okay. But that's the reality of the situation. But I just think that each dentist needs to not just dive into things, but look at, is it worth your time, or are you going to be more successful and busy doing the other things? And is it about keeping your interest level, or is it making you crazy when you're doing it?
Well put. I've noticed that business models are changing in dentistry. I mean, and the one business model I see that's really changing is the pediatric dentist who opens up with an orthodontist. It's kind of like 1 + 1 = 3. And the retail people figure this out where, you used to have to go to the baker, the meat, the butcher, the baker, the produce man, and then, 100 years ago in New York City, they started moving those together. And now you go into a grocery store and it's got the butcher, the baker, the candlestick maker. I mean, they even have candles. They really do. And I've seen that lately in the last 10 years. You go to a pediatric dentist, obviously you ask any pediatric dentist, how many times a day does mom ask, is my baby going to need braces? And then you say, oh, well, you're talking about your mom having to make another appointment, another couple of weeks, another month going somewhere else. And putting that under one roof, it looks like when a pediatric dentist and an orthodontist are under one roof, they really explode. It's really convenient. And I'm starting to see that with periodontists and prosthodontists. Periodontists will get a perio case, and it'll need a bunch of implants, and it's really tough. It's called channel conflict, where a lot of periodontists say, well, if I start placing implants, then my oral surgeon's not going to send them to me. If the periodontist starts restoring the implant, then no one's going to refer to him. But patients, we saw that Texas lawsuit where a guy said he specialized in implantology. The dental board said that's not a specialty. The ADA only doesn't recognize implantology as a specialty. The judge said, well, the ADA is a membership club. It's not an agency. And indeed, the guy only did implants. So you can see the demand that the patient, like if I had to have an implant, I wouldn't want to go to the periodontist, place an implant, and to you and have it restored. I mean, I'd like the one-stop shop. And so I'm seeing that starting to take off with periodontists and prosthodontists. The other one was Clear Choice, where they get an oral surgeon or a periodontist to place the implants, but they have a lab tech in there. So the lab tech, the case, and they do the surgery, put on your teeth, any adjustments, it's all there. Do you see that as a real big deal in your specialty, prosthodontists? I mean, are you seeing prosthodontists hook up with other specialists like periodontist or Clear Choice or lab techs? Are you seeing any of that in Beverly Hills?
Yes, I am seeing that. And I agree with you. There's some practices where now they have their own group practice. And there are a lot of offices where they'll just have their own specialist. They'll have their own prosthodontist, general practice that might have their own prosthodontist or periodontist. But the problem is, it's on one hand, it can be great for patients in terms of convenience. And I understand why doctors are trying to do it, because they want to keep all the business basically in-house. But the problem is when you have the patient who has, who's unhappy with something, when there's a difficult case and there's some liability. the advantage of having different offices and different specialists in different areas, the patient is going to that one prosthodontist or one periodontist who they really like and who they think is the best for them. And if there's a problem, you've just spread out the liability. And also, when you have different providers in different locations, and each one of us is telling the patient the same thing, that actually helps with the credibility of what we're recommending. It's a little trickier when everything's under one roof. So, there are pros and cons of both sides. And I think people have to decide, are you doing it because of space sharing, cost sharing factor, like a business decision for your own practice? And what about the liability? So I've considered that myself in the past, but I'm concerned about if I have an endodontist or if I had a periodontist. Well, I couldn't have a periodontist because that would eliminate all the referrals from other periodontists. So I would not have that in my office. And same, and oral surgeons need their own facility. But that concern also came up when I was looking at, well, what about having an endodontist? So in the end, I've stayed by myself. I considered adding a general dentist, and I could mentor them with their cases, and they could refer me some of their difficult cases. But that would be a business decision, and I think every dentist has to weigh, like, are you looking at it from a business standpoint, but what about a liability standpoint? And then patients should decide, are you happy with the person who's in-house, or would you like a different referral? It doesn't mean that patients have to stay within that office.
The next word in that sentence was biomimetics, or biomimicry is the emulation of the models, systems, and elements of nature for the purpose of solving complex human problems. When you say you are utilizing an interdisciplinary biomimetic and facially generated approach to dentistry to provide all patients with a natural and healthy result to restore their health and function. What do you mean by biomimetic?
So biomimetic, that actually, I think the person who made that the most famous and brought it to the forefront was Pascal Magne. So Pascal is from Switzerland and now researcher and educator at University of Southern California, USC. And there has been so much in the past where every single tooth is crowned and veneered. And not every patient needs to have every tooth crowned and veneered. If for example, I've had a number of patients who fractured one central incisor. And typically a patient might be informed, okay, well, now you need 2 veneers, or even sometimes they'll be told you need 6 or 10 veneers. But in fact, there's a number of patients I've treated and who tend to be younger. That's not necessarily the best treatment option for them. So when I've had a more youthful patient, a younger patient, where we need to know that that tooth is going to last another 100 years for that patient, I've actually successfully executed bonding the fractured piece back on the tooth, or reconstructing the tooth with bonding, or sometimes when it's fractured off at the gum line, instead of extracting it and placing an implant. And I love implants and I love restoring implants, but for a patient who is a teenager or their mid to early 20s, we need to know that that tooth is going to last 100 years. So an option exists where we rebuild the tooth, do a buildup, use orthodontics to orthodontically extrude that tooth to have a ferrule effect, and then restore that tooth with a crown. And I've used that technique for patients who are younger, all the way up to 75 years old. And it just depends on that patient. Sometimes if their gum line is too high, if they have a high gum line and that particular tooth, the gingival margin is apical to the other teeth, the extrusion technique actually works very well and allows them to even out their gingival margins as well as to save their tooth.
That is very neat. Yeah, that makes me think of so many things.
Yeah, I know. Sorry, it's
no. That is neat. I want to say it another way. right now there's a lot of kids from the COVID class of 2020 that, to put this in perspective, Dental Town came out in 99. We started programming in 98, but it came out in St. Patrick's Day 99. So 21 years. It's had free classified ads. It's one of the most popular sections of the site. And it's always been about 5,000 jobs listed for an associate dentist and about 1,000 offices for sale. Now there's 2,000 offices for sale and only 1,000 jobs, and all the jobs are only in DSOs. So a lot of kids are thinking right now, well, hell, if I can't find a job and maybe it's a great time. It's August now, school starting, to go back and become a specialist. You're a prosthodontist. What would you say to a kid who is thinking, I am? What do you think of them going to prosthodontic specialty? I mean, do you think it's a good specialty? When you decided to go into it, did it look better then than it does now? When you go back to when you started prosto school, did that windshield look like a rainbow with unicorns and like great idea? And now that you've done it, you're looking in the rearview mirror saying, bad idea, I should have been an orthodontist or a general dentist. What would you tell the kid thinking about prosthodontics as a specialty?
Well, I went into prosthodontics. I think in the end, everybody has to do something they really, really like and are passionate about it. I hated endo. I could not do endo even if it was very lucrative, and I still feel the same way. And apparently it is very lucrative. I just cannot stand sitting there and twirling, no offense to any endodontists, twirling a little reamer or file. I went into prosthodontics because I like the variety, and there's so many different aspects to it. There's always something else you can do. And now I have to say that I've incorporated some orthodontics into my practice and very minor perio. So I like that. I do implants. I can have in one mouth a little bit of orthodontics to straighten out the lower anteriors, extrude a tooth, and prepare them for their reconstruction to have a better result, work out their occlusion, and there could be implants in there and some crowns and veneers. And all of that all in one mouth. So that's a nice thing about prosthodontics. And there could be another mouth that has implant superstructure and removable. So from an interest perspective, it's a great specialty. In terms of business aspect, the problem with being a prosthodontist is, as my father actually pointed out later, was that all
your father was a prosthodontist?
No, my father was a smart businessman. He said, "Why are you becoming a prosthodontist? Because the skills that you do are the same skills that general dentists do, and so they may not want to refer you a patient, and that is a problem. Or a lot of general dentists don't know what prosthodontists do, or they think that we only make dentures, and in my area, we have general dentists of different skill levels and different comfort zones. And I just tell them, I said, please send me whatever you're uncomfortable with and whatever you don't want to do. And for every dentist, it's different. And so some will do more and some will have a different comfort zone, or some will be very busy and very successful, just limiting their practice to more basic things, and I've had some very successful general dentists tell me by the time they're preparing a crown for the third time, it's just going to take too long. So they prefer to refer it out, or they used to send me the second molars or any bridge longer than 4 units, because they realized they were very busy, very successful, and they could treat multiple patients at the same time if they're more efficient with their time. And then others just want to do something more challenging. And, I leave that up to my colleagues. And all I ask is just send me whatever you don't want to do and anything you're uncomfortable with, because I consider it an opportunity. And I'm even fine for my colleagues to send me that difficult patient, or the patient that they see at the country club every week, but they don't want to have a problem with, or someone who is asking just too many questions, because my staff in my office are trained to work with those patients who are more demanding and more opinionated about what's going on in their treatment.
You know, they when I was in school, they said dentistry treated 3 diseases, and they were cario, perio, and I wish something occluso. Can I say perio, cario, and occlusio? I need a good synonym. I need a thesaurus. But when they come out of school, they universally will all tell you, well, I understand the caries. I understand streptococcus mutans. I can read them on an x-ray. Perio, I can probe. They get all that. But they always come out of school so confused about occlusion. And they always say they need to learn so much more about occlusion. And then they don't know if they want to go to LVI and learn neuromuscular, if they want to go to Pankey, Dawson, Ross Nash, Spear, and learn the traditional occlusion. Why is occlusion so difficult? Are we the ones making it more than it is? Or are we the ones making it complicated, or is it not taught well? Why do they come out of dental school $400,000 in debt, and they already feel like they need to go spend several weekends with Kois?
I think because I have to say, if I was not a prosthodontist, occlusion would be something challenging as well, an enigma. Because when you are going through 4 years of dental school, there is so much that is new, so much that to learn. And I remember just in the first year of dental school, just trying to even remember what a tooth looked like. What's the cusp of Carabelli? How many, is this a second premolar? Is it a first premolar? And remembering the tooth numbers. It was just so much all at one time. And then suddenly you're learning amalgams, prepping, and shaping of the resin fillings, the different composites and the design. We did a lot in ortho, how to scale, perio, and diagnosing everything. There's so much. And now the students must also learn implants and veneers. So I think that there's just too much information in a very short time. And when do they get educated on occlusion? In 4th year, at the very, very tail end. And it tends to be theoretical. It tends to be a lot of information, and it's very philosophical and theoretical. And I think it would be different if they just had a number of patients and just said, let's adjust this patient's occlusion on that one crown. I think if they just broke it down to, let's make sure everyone knows how to adjust the occlusion properly on one crown, and then go to maybe 2 crowns or on a denture, perhaps that might be more effective.
I thought the occlusion was you just grind the new crown out of occlusion, and when there's no more marks on it, it's all good. Are you saying that's not right? I mean, when you look at occlusion, and they talk about pathological or occlusal wear, fractures of teeth, cervical dentin hypersensitivity, teeth hypermobility, firmitis, vertical bone loss. But when you get to have fractions, they come out of these 2 schools in our backyard, and they don't even know what caused an infraction, because they'll say it's grinding, but then the kids will say, okay, well, they show up in all the grass-eating antelope and deer and cattle. Some people say they're brushing wrong. It's like, okay, well, deer and cattle don't brush their teeth. And then the occlusion people will say because it had the wrong occlusion. But then the flip side of that is if the oath is first do no harm, when someone has an infraction, I've noticed this after having my office for many years, is that the patients who didn't accept treatment taught me as much as the ones that accepted treatment. I'll give you 2 examples. You used to have that baby tooth. When I got out of school in 87, I had a baby tooth. There's no permanent one underneath it. Oh, you got to pull that and do a 3-unit bridge. Well, a lot of people didn't have the money or decided not to do it. And now they're still in my practice 32 years later with that baby tooth there. And now I'm sitting here thinking, my gosh, I wonder how many baby teeth I pulled that I should have left alone. And then it's the same with abfractions. It's like a lot of people didn't get their abfractions. I noticed that some people will put composite on in class 5. Some will send it to a periodontist and do a graft. But you have a whole bunch of patients that didn't do anything. And there they are 3 decades later and they're fine. So what would you say caused an abfraction? And what would you tell the patient? Well, if you didn't get that fixed, what would even happen?
Well, again, I think every patient's different. And so some patients, if I see that patient, if it started small and it's not changing, then, that's fine if they want to do nothing about it. But if you see that it's getting worse or these are new and patient says, gee, I'm chipping my teeth as well, I'm getting headaches, my muscles in my jaw are getting sore, my face is changing, I'm getting headaches, then I would encourage them to have an occlusal guard. I have a friend who just had similar experience. And so in her case, I said, well, let's make an occlusal guard. So we're not necessarily rushing in to go fill them. And when they get to a certain size, I tell my patients that you have a gouge in your tooth. It's kind of like when the lumberjack is going to chop a tree down, he makes a notch, and that can weaken the tooth. But more importantly, that is an area where plaque tends to collect. So if plaque tends to collect there, then the patient gets more susceptible to decay or periodontal disease or gingivitis. And so every patient is different. I always feel that some of those abfraction lesions could be due to a combination of clenching and grinding, but also sometimes due to their brushing habits. So it's a matter of determining for each patient which is the stronger of the two elements, and intervening. So if the patient's brushing very carefully using a soft brush, then the next thing is intervening with the occlusal guard.
Now, are you placing implants?
Not yet.
Not yet. Now, back to channel conflict, do you feel as a prosthodontist, if you start placing implants, that would hurt your referrals from people who make a living placing implants, like periodontists and oral surgeons and implantologists?
I think it may or may not. So, in the end, when as a prosthodontist, I'm already always working with so many general dentists who are doing a lot of crowns, a lot of veneers, difficult cases. So I think in the end, those who do similar work, when they refer a patient to me, they can communicate the concerns to the patient better. So if I'm going to place the odd implant here, it's going to be case selection, where it really makes a difference to maybe that position, maybe a central incisor or something like that, where I'm going to place exactly where I want it. Or it may be the very easy cases. But if I'm placing implants, it also means that I'm very attuned to case selection. And there are certain cases I'm not going to refer out, but I'm also very thorough and capable of communicating the complexities to the patient and saying, this is why I need you to go see this other surgeon. And yes, I do them, but I'd like you to go see Dr. XYZ, periodontist or oral surgeon, because I think that they're going to handle their case a little bit better. And I utilize a lot of different specialists because there are a lot of times where it just makes sense to spread the responsibility out.
Yeah, I love my pediatric dentist because even though I had 4 kids in 60 months and they made me 6 grandsons, I love kids, but I don't want to work on them. And then we have a guy down the street that got his fellowship in the American Academy of Cosmetic Dentistry, and it's doing anterior veneers on women who are expecting that, they're 50, they just got divorced, they're ready to go back on to match, and they think that my veneers are going to make her, a beauty queen, and it's like, oh my God. And TMJ, oh my gosh. I can't believe anybody would say, oh yeah, I want to be a pediatric dentist. I want to spend my life with crying children. It's like, wow. What was your next best idea? And the only thing worse I can think of is this new oral medicine and oral, what's the new specialty? Oral medicine and
oral pathology.
Oral pathology. Could you imagine a life of TMJ? I just want to practice on crazy older women. That's all I want. I want crazy ladies with crazy eyes. It's like, my God, I love general dentistry. I love to be able to be seeing that emergency, just thinking, okay, who am I going to send this crying kid to? Who am I going to send? I just love to pick. I want to switch to implant systems because, as you know, a periodontist or an oral surgeon who has a system, they want to sell their idea of choosing that system, whether it be Brandmark or Straumann or Neodent or whatever. But you're a prosthodontist. You get cases sent to you. How many different systems have you restored in your career? I mean, it's
restore
probably
everything.
Yeah. So, how many systems have you restored? 10?
I have this one mouth that actually has Straumann, Astra, because he's gone to different surgeons on his own prior to settling with me. But he has Straumann, Astra, Nobel, Southern, all in one mouth. It makes it more complicated. It definitely makes it so much more complicated because I'm constantly having to think, okay, now we're doing this tooth and this provisional, and then we're going to do an impression. Which torque driver am I getting? Which wrench, and or which screwdriver? Because each system likes to have their own driver, so you have to keep buying these different instruments. I think I've probably restored at least 7 different systems.
Now, are you agnostic to systems? I mean, if she wants to start placing implants and she's got $400,000 student loan, she only wants to buy one system. If she's asking you right now, okay, if I was going to just buy one system to start out on and to learn, how would you guide her on that?
I think I would have to say, there's a few things. I happen to like a particular system, which I'm not necessarily going to disclose here, but I like a particular system just because for me, it's very straightforward, easy. And each system is going to be, to some degree, once you know the name of each different part. So I've restored all these different systems. There's one I find particularly easier, and their parts are more common. But another thing that's important is having a good support. So like a good rep. Does that company have good reps to support you? Because it certainly helps. Sure, I can go online, and I think many of these companies are now, or several, are now trying to streamline their overhead. And I think they're trying to eliminate some of their reps, or they're augmenting their system by having websites where their doctors can go directly on the website and choose the parts. And some websites work better than others, but it's certainly much easier if you just say, hey, so-and-so, text them. In the old days we would call, but nowadays I just text them and say, I have this patient coming in for impression, and this is the brand. Here's the diameter of the implant. I need the impression coping, the replica, the abutment, and the screw. And I want a tie base or something like that. And it's just so nice that they just organize everything and get it shipped out to me. And sure, I can go on the web page, and I have another rep from one company that will send me the catalog. Like they'll text me a picture of the catalog, and you know what? I just don't have time. So it just makes it so much easier if I can just send a text message to the rep, and they'll just send over whatever I need right away.
The rep is huge, and
the rep is huge.
Yeah, it's huge, and that's why it's the same thing with the dental CPA. There's one firm that's got like 6,000 dental CPAs, and another one has 2,000. And people always ask me, well, which one do you recommend? It's like, well, dude, you're in Nashville, Tennessee. You might really connect with one of them.
Right.
It has nothing to do with the other one. And, man, when I was getting my fellowship in the Mission Institute and my diplomat in the International Congress of Odontology, I had a rep that actually lived within 5 miles of my house. And, I mean, she could just be there in a minute. I mean, if anything happened, the rep was everything. The young kids, I want to hold your feet to the fire because they ask very specific questions. A lot of them, you know, a good quarter to a third, they come out of school, they're going to work with their mom. There's family. You know, dentistry is a very family business, especially in India and Brazil. My God, I ate dinner at a dentist house in Brazil. There were 35 dentists in the family tree.
Wow.
And then in India, it was like something like 28 or 30 or whatever, and they actually all lived in the same house in India. Well, it's not the same house, but, you know, they just keep adding on and adding. It's like a big mansion with all these extra rooms. So it's a very family thing. But when they come out of school and they're young, they learn all this theory in school. The only reason they became a dentist, their mom, she's their idol, and they're hearing two competing things. And number one, she wants to ask another person outside the family, to you, when can you just take a triple tray for an impression for a crown, and when do you need full arch mounted on a semi-adjusted articulator? When do you have to pull out an articulator, and when can you just get by on a triple tray? And then, to make it even more complicated, now you have scanning. And now some of the scanning softwares have, the mounting and the bite and all that kind of stuff like that. So how would you answer that? Are you still using Impergum, or are you switched to scanning? Do you ever use, as a prosthodontist, do you ever use a sideless Premier triple tray, or is it always full arch? And how often do you have to mount on an articulator? So go over.
Okay.
Okay.
Great question, but how much time do we have?
I'll stay up till midnight with you.
Okay, so great questions. I do use triple trays too. So if I'm doing a single unit, 1 unit or 2 units together, and if they're in one quadrant, I can safely use a triple tray very easily, because it's nice that you already have the patient's occlusion, and you have to make sure that the patient has a stable occlusion. So if you, prior to treatment, you've detected a lot of fremitus, a lot of mobility in the teeth, then the occlusion may not be stable. If you know that the patient already has a slide, it's not necessarily stable. So you might restore the patient with a crown and then find that there's a problem later and the occlusion's wrong, and not something that you can manage easily without remaking the crown or redoing it or adding. So you want to start off with the patient. It doesn't matter if I'm doing single unit, a bridge, or a full mouth reconstruction. Before I go to do a final impression or finalize my restoration, I want to know I have a stable occlusion and stable vertical dimension. And so if it's a single or double 2 units, I can safely use a triple tray. Because I have to have enough teeth adjacent to that area that I'm restoring, so that when I make the impression, I'm going to have a stable vertical stop. I might even use a triple tray if I'm doing an anterior bridge, or I cannot use a triple tray at all for implants, because I typically will use, you're going to use an impression coping, and there's no way to have the patient bite down normally if you're going to be making an impression of an implant. So when I'm talking about using a triple tray, I'm talking about restoring natural teeth. I can use a triple tray even if I'm doing several anterior teeth. But the key is I have to have a stable occlusion and stable vertical stop beyond those teeth that I'm restoring. So that way, the lab, when they're pouring up their impressions, they have models that they can articulate. You also have to have a vertical, a tripod. So if you're restoring anteriors and you just have left and right, but there's no anterior stop, then that model can tip. In terms of doing a reconstruction patient, again, you have to have a stable occlusion, stable vertical stop before you start going into final impressions. Commonly, what I'm going to do is I'm going to make sure I have a tripod. So I have a couple of posterior stops and one in the anterior. And it may be like I'm every case is a little different, but you always have to look, okay, is there a contact in the left side? Is there a contact in the right posterior? Then will I have a contact somewhere in the anterior, preferably in the centrals, or am I going to make a little stop? And sometimes I put some composite on the lingual of something, or built up composite on one prep, and then I've made my impression, but it's very clear where to shave that off. So there are a number of different things that I would do. If I'm going to be restoring a patient's full arch or doing upper and lower arches, then it is much safer to use an articulator. If you're doing something where you're largely not changing the patient's occlusion and you're just replacing 1 or 2 units, then you can safely use, I think labs will use a hinge articulator, something smaller, something more convenient. It really has to do with how many units you're replacing and how much potential change there will be. And I typically have a good prototype before I start. So if the patient's occlusion is excellent to begin with, and you're just changing a few units, then you don't need to make anything extensive. If I'm replacing 6 to 11, I need to have a decent provisional so I can guide. I have an idea for the patient what they're going to look like when they're finished. And the provisional is a prototype for the patient so that they know how long their anterior teeth are going to be. They have an idea of the comfort level of their occlusion. And my lab also has an idea, because I'm going to send them a model of my provisional. So they need to have an idea of how long, what size shape I'm talking about for the teeth, and what occlusal scheme am I going to have? Is it going to be steep, or is it going to be more a flatter occlusion? So anything that I am, whenever I'm restoring anteriors or a full arch, I'm always going to take the time to work out the aesthetics, the occlusion, and the incisal edge position, the lip support on my provisional. And then I'm going to take the time to mount it and also make a model of, or diagnostic cast of my provisionals to provide that to the lab. And I'll take a whole series of photographs for the lab as well.
And where are you on your journey from Impergum, polyvinyl siloxane to digital scanning? How is that journey going for you as a prosthodontist?
So right now I'm still using PVS impression material, but I'm actually looking at an iTero scanner, actually possibly Monday, and considering different scanners for this fall. And I had considered this a few years ago, but when I looked at a dye that was produced by one of the scanners, this was the year that Academy of Boston Integration was in Seattle, so maybe like 3 years ago. I looked at the dye that they produced and I thought, like, why are your margins not as sharp as my dye margins? Like, is that because everyone handled it? Or is that because of the technique they used to produce the dye? Or is that's the level of the scanning? So they didn't answer it, and that didn't make me comfortable. But I think things have progressed. I heard this past year in Chicago, Academy of Fixed Prost, they actually said that just to date, for any patient that's having a full mouth reconstruction where you're having the entire arch, it is still not recommended based on research to use a scanner, that it's not adequate in terms of scanning and utilizing that for the impression. So for when I'm doing a full arch restoration, I would still use a PVS impression, but I plan to use my scanner for orthodontic reasons and also shorter restorations, single units.
So that you just answered my next question. I've noticed that iTero is owned by Align Technology, which owns Invisalign, and if The only two segments of dentistry that's growing double digit around the world for the last decade is implantology and clear aligners. Every single cleaning exams, x-rays, fillings, simple endo seems to be going right with the consumer price index, the growth of the economy. But the double digit growth, clear aligners and implants. And if you have any thoughts of going into clear aligners, it seems like you go into iTero. And if they have no desire to get into clear aligners, they seem to be going with out of Copenhagen 3Shape. Did you?
So those are the ones.
So did you compare iTero to 3Shape? And I noticed 3M sold off their True Def, and everybody told them at the time, you had to spray a powder. And they got all these big wigs. I've seen this rodeo before. Whenever a big company with a lot of money has a problem, NASCAR. I love NASCAR better than dentistry, even though I never watched NASCAR evers, because the NASCAR driver has all the insignia of who pays for him. You see Ford, Chrysler, GM. You know who owns them, and you know who owns the big speakers, because whenever they got a big problem, they get out their key opinion leaders to come out and tell you how the powder is no big deal. It's no big deal.
We don't want to use powder.
And I saw that rodeo before when during the cosmetic revolution, everybody you talked to on Dental Town was having sensitivity with bonding agents. So they got all these big speakers to write, oh, it's not the bonding agent, it's you. You're over drying it. No, you're under drying it. Oh, you didn't have a rubber dam. Oh, you rubber dam. It was like 100 problems, and the only people that listened was the Japanese. The Japanese were the only ones. They were the only ones who contacted me and asked, how big of an issue is this, blah, blah. And then they came out with their Clearfill SE, one step, where just, no sensitivity, where they're etching and the deal. And it was so funny how Clearfill SE got rid of all the sensitivity for everyone that used it. But the other companies were just trying to tell you. But 3M, I saw that rodeo before. Instead of telling everybody why the powder was no big deal, they should have just figured out a way to make it not need powder. So you compared iTero to 3Shape, and did you solely pick iTero because you have an interest in clear aligners, or why did you not go with 3Shape?
So I'm actually still in the comparison phase. And the two that I happen to be interested in are 3Shape, just because I really like how it looks and the presentation of it. But I'm looking at iTero because I do a lot of clear aligner therapy. I use both ClearCorrect and Invisalign, and there's another system called ACE. So I can use any of those systems, but there's some features that iTero has that I actually find attractive. How it does the before and afters, and it streamlines things. I do understand that ClearCorrect also is connected with a system, and incidentally, iTero is now connected with Zimmer. So my Zimmer rep is bringing the iTero out to show me, and possibly on Monday.
Zimmer Implants is showing you the iTero rep?
My Zimmer Biomet rep is bringing iTero. Is that amazing?
Well, the other news, Zimmer, they bought, didn't they merge with, didn't they buy 3i and other ones over the years? But Zimmer, a year ago, my people follow me on LinkedIn, since I have a dentist MBA from Wall Street, were saying it looks like Zimmer's for sale. And I thought, wow, I wonder why they're getting out of dentistry. I wonder what's going on. But if the Align Technology rep for iTero and Invisalign is now the Zimmer Biomet, wow, that's breaking news for my walnut brain. And who do you think ClearCorrect is
they're affiliated with Straumann. So right. Straumann bought ClearCorrect, I think, about a year ago.
Right. But I thought, is there a scanner involved with ClearCorrect and Straumann?
Yes, they have. And I unfortunately, they priced it out for me, but I haven't had time to look at it. And I'm not even able to tell you what is the name of their scanner, but I knew that would be happening in a short time because, Straumann, of course, would want to retain all their business. And I think that's nice that Straumann bought ClearCorrect. and I just knew it was a matter of time before they also had their own scanner. But I unfortunately.
Wow. So I wonder. Well, if you find out what the Straumann scanner is, will you tell me?
Absolutely.
And you said the other clear aligner was Ace clear aligner.
Ace, yes. So Ace
ACE.
was ACE, and I have to say, impressive. It was developed by a USC graduate. This USC graduate invented and marketed and sold ultralight optics before he finished dental school. And then it became like a top seller. He also developed another product I really like. It's called, I call it microblade, but it's a mirror that blows air, which now we can't use it, unfortunately. So when you're working and you had to blow air, it was very efficient because it was intraoral mirror that you could just dry everything off with. But unfortunately now we can't use it because we have to minimize our aerosols. But then he also developed Ace, which is a competitor to Invisalign and ClearCorrect, and you could do it on your iPad.
And that's another thing, Dennis. A lot of them don't appreciate. I mean, I understand this is the toughest time. It's the toughest I've seen in my lifetime. I mean, I haven't seen anything this difficult than gosh, it was a bubble, a pandemic, inequality, racial riots, and now an election. I mean, I'm just waiting for ET to come home or get invaded by space aliens. So crazy times, but you're having to compete with the dentists across the street, you think. I mean, my gosh, competing with these dental companies, I mean, it's just, it's a whole nother level of competition. I mean, look at restaurants. I mean, dentistry at the bottom was closed down like restaurants, and now we're back to 71%. Restaurants aren't even back to 20%. They're still down 80% of their revenue. The only thing good about this pandemic is they closed my gym down, so I haven't had to work out. So now the time that I used to work out, I'm being proactive. I just eat Cheetos now during that entire time. So I'm not aware of many prosthodontists doing clear aligners. Is that a Beverly Hills 90210 thing?
I think there are a lot of restorative dentists. I think most restorative dentists in Los Angeles are doing clear aligner therapy. And, I found it really helpful because when my patients are coming for different appointments for their restorative needs and their hygiene, then I could control where their lower incisors and their canine positions would be. And I've utilized their implants or implant provisionals as anchorage. So I've actually found it very beneficial. And then the compliance rate was much higher. I used to refer all my orthodontics out, but then I had to keep delaying my restorative phase. And back then, it was even tougher. We had to take a photo, upload it into our email, and then send it over, and then make the phone call. And so our poor patient would have to come see me and then go see the orthodontist. They were always going to two of us for every orthodontic evaluation. And it just made things, for pre-prosthetic cases, it just streamlined things. And from what I heard from the orthodontist, they would rather me just handle the pre-prosthetic orthodontics anyway, because we would be asking them to move things 0.5 millimeter or 1/4 millimeter and this way and that. And I always knew exactly where I needed it for my occlusion or my restorative reasons. And it was just too much fine tuning. Whereas when they're treating children and adolescents, they just knew they had to line up all the teeth on the arch and work out their occlusion that way. It was just, they were trying to move things to something where I could visualize where I wanted, but they might not necessarily see it. And there's a lot of shifting back and forth. So I think it worked out better for patients where if it was for pre-prosthetic reasons, we just kept it in-house. They had to just see one provider, go to one office, and it took up less time for the orthodontist and it took up less time for us as well.
So are you working with Ron Nguyen, the founder of what was that, he was the founder of Ultralight Optics and now Ace Aligners? Are you working with him, or are you Are you doing beta form or anything?
Oh no, I haven't, but I've purchased a number of his products.
And is he close to you?
He's in Orange County. He's in Irvine.
He's in Irvine. Okay.
Yeah.
Very interesting. I want to go back to if I know we've gone over an hour. Can I still have some questions? Are you okay with overtime?
Sure.
I want to come back to the post versus the ferrule. So there's two schools of thought on Dental Town, and the ferrule to kids actually came to dentistry via barrel making. They figured out hundreds of years before G.V. Black and Pierre Fichard that when you start stacking barrels, they would pop. And if you had this big 50-gallon barrel or however big barrels are, and you put just a little 2-inch metal around the barrel, that was called a ferrule. And then a really good one would cut the upper half and lower half, so you'd have like an equator and a Capricorn and whatever, 3 ferrules. And there's a lot of people on Dental Town that think if you have 2 millimeters all the way around the tooth, that's what you call a ferrule, it's going to be good. Other people sit there and think, you know what would be better is a ferrule with a post. And I'm going to put a post in there. And then there's a whole bunch of people who say the only function of a post is to fracture the tooth. So might as well put in 3 posts. So where are you at between a post and a ferrule?
So, and this is another excellent question and great to clarify that. So the research actually shows you need a minimum of 1 millimeter ferrule. And if you have more, it's obviously better, 1.5 millimeters, 2 millimeters, all the better. And that research actually was completed at the University of Washington by one of my predecessor colleagues, Warren Libman.
Okay, so she's biased. That's not even, she's biased. She's just endorsing her homie, but you thought it was good research?
It was excellent research.
Okay.
So I always make sure I have that minimum, and the more the better. And then in terms of post, I try always not to use a post unless I absolutely have to. So the purpose of the post is supposed to retain the buildup. And if there's, excessive loss of tooth structure, then I'm going to use a post. And typically the place that I might need a post is, let's say, a canine that's fractured off at the gum line, or a molar where it's significantly broken down. If I'm only missing one wall, I could use a pin. If there's the possibility of bonding everything to that tooth, if that molar is broken down and I have significant tooth structure all around it, then I can bond to it. If I am missing just one wall, I might place a pin. If I'm missing 2 walls or part of 2 walls, I might place a pin. But if I'm missing more, I would prefer to anchor that buildup using a post, and that's held up very well for a long time. As for fracturing, yes, if you put a post in, you do increase the risk of that tooth fracturing or the root fracturing. But in the end, I think it boils down to, did you have enough ferrule? Did you manage the occlusion properly? And if it's a grinder, does the patient have a guard, and are they really wearing it? But I think a lot of failures have to do with the occlusion.
And I really like to focus on, all dentists are smart. I know so many dentists that were valedictorians of their high school class. They always got A's in physics. They're just really, really smart people. So I don't like to ever talk about what they agree on. I like to talk about, well, where do they completely disagree? And I think one of the most glaring things that I see, and I don't want to ask a periodontist because they're economically biased towards the answer, but why is it that 20% of the dentists are always doing crown lengthening and 80% say, man, I went my whole career. I retired it from 25 to 65. I never did it. So how do you have 80% of the dentists who get A's in calculus and physics and biology and geometry just don't buy into or do crown lengthening for some reason, and 20% think it's the holy grail of dentistry and crown and bridge?
Well, but I think you need crown lengthening when, there are times when you need crown lengthening when you don't have adequate exposure of the ferrule. So in the end, to me, you have to have adequate ferrule. And how are you going to get it? Are you going to achieve that by crown lengthening, or are you going to achieve that by orthodontic extrusion?
And what do you prefer on that? I mean,
Well,
are you more periodontist, or are you more orthodontist extrusion? Where do you fall on that?
but I think those indications are different. So the cases where you can do extrusion, maybe a tooth is fractured off at the gum line, the gingival margins are ideal. So if you do crown lengthening, now you've just altered the gingival margin, gingival architecture for that tooth, and that canine now may look really long, and or that central incisor might have the gingival margin go up and become unattractive. On the other hand, if you don't have to gain that much, maybe you can do crown lengthening, or if that gingival margin happened to be lower, sometimes when you do the crown lengthening, now the gingival margins look better, or the end point of where the gingival margin ends up not that noticeable, like it's not noticeably higher. If it's a posterior tooth, it's probably easier and more amenable to being treated with crown lengthening, because the teeth that you can extrude, you have to make it worthwhile, you have to have adequate anchorage, you have to have an adequately long root, it has to be fairly straight, it can't be a root that has an excessive curve or bend to it, it can't have a bulbous tip, it's not going to work to really extrude a molar, it's not really going to be time efficient. So generally my extrusion cases have been premolars, canines, or incisors.
And I hate to, I don't want to throw you under a bridge and make you upset with your lab or whatever, but you know, when Delta sends you a PPO, and 95% of dentists take Delta, and you know, if you're not going to be able to charge more, you got to reduce costs. And a lot of people are really seduced by Glidewell's low cost, especially zirconium. You know what I mean? I mean, you can get a zirconium crown for under $100. But as a specialist in Beverly Hills, I mean, would you ever do a single crown at Glidewell for $99, or would that be like sacrilegious and you would have to use a premium, expensive lab in Beverly Hills? How would you weigh that decision? Because some people, I firmly believe some people just think if it's low cost, it's cheap. Like, you know, and, you know, they'll buy a $5,000 Gucci purse as if it was
Absolutely.
made by, you know, nuns who, you know, made it with their own hands in a monastery or something. So where do you fit on, where is low cost like Glidewell in a single unit crown versus, I mean, I'll tell you an example. When I was going through LVI, they recommended this lab up north. They charge $400 a unit for a veneer. Now, this is a true story. You can't make this up. This is stranger than fiction. I did this. When I got the veneers back, I mean, they looked so beautiful and natural. I actually thought they were human teeth. I put them on this lady, and she owned some New York steak and ribs place up the street. And oh my God, she almost cried. She hated them. She was from New York, and I had to cut them all off. I sent them. I got her. You know, they had grooves and stain. Oh, they were just perfect. They were just perfect. I chopped them all off and sent them for some toilet bowl porcelain chiclets and redid the whole case. So I already had to pay a $400 lab unit. So then I did the next guy was $100 a unit, put in 10 chiclet teeth. Now she's crying because she loves it so much. They're perfect. I mean, you know, it matched her bleached blonde hair and her red lipstick and all that stuff. So I know there's the individual person at stake, but like, do you ever use the low cost Glidewell, even though you're a prosthodontist in Beverly Hills?
Okay, so
and I know Newport Beach is right around the corner from you, and if that's channel conflict, and you're like, you don't want to run into Jim Glidewell at a fundraiser and have him give you a dirty look, that just say channel. If anybody's on my show and doesn't want to answer, just say channel conflict and pass.
No, I'm gonna answer, and then
okay,
you can decide. So, well, first off, I think every dentist needs to decide where are you going to practice. like what style are you going to practice, and what niche are you going to be in, and what is your comfort zone? So I tend to provide what I would want in my own mouth, and I prefer to educate my patients on that. And yes, every now and then I have this one patient, she says, I want these big white teeth that poof my lip out. And I've said, these are really too long. What about if we mark them? And I've marked them for her, and I took photos. What if we reshape them and shorten them a little bit? They're going to look so much more natural. How about this? She said, no, I want these really big white teeth to poof my lip out because it's less expensive than filler if she just has these big teeth. And so when she's lost some teeth, I've had to replace the big white teeth. And when I've had to refer to a specialist, I will preempt her visit and say, I didn't make these. These were done somewhere else, and I had to just replace what she had. But that's not the style that I wanted. But when you know what style your patient wants, then you can decide, are you going to use the more expensive lab that can produce those individual crack lines and stain and translucency, or are you going to use a less expensive lab? I tend to prefer a boutique lab. So it's not the pricing necessarily, but I want to use a boutique lab for me because I want to be able to tell them exactly what I want and have a conversation with the lab and the technician. So I have not tended to use one of those large labs. And then in terms of addressing the issue about the fee, it would be great if when we know what, patients commonly say, what is the cost of this? I don't know. I need to see you. I need to evaluate your mouth. And then I need to get to know the patient. What are they looking for? And how complicated is it going to be to satisfy their needs? And are we just talking about restoring 6 teeth or 8 teeth or 10 teeth? Or are we having to reposition their gingival margin, whiten their teeth, or what are we matching? All that. And then when we provide an estimate for a patient, we need to know, are we using a more advanced lab? And we have to incorporate, there's 2 ways of handling this. Are we going to incorporate that lab fee into our fee and give an estimate of what that lab fee is going to cost us? Or are we going to do what is a better idea, is quote them a fee. This is our fee and this is the estimated lab fee. And then that way, if the patient decides differently, you can switch it and the cost may be different. I think it would be great if all dentists went that way and we just quoted, and this is what they do in Canada. I think Frank Spear teaches that in his institute, to quote your fee and then quote the lab fee separate. Do I do that in my office? I prefer to do it that way. We haven't made that switch yet. I still think that's a better way, but in the end, I think patients like to know one number. They just want to know totally what number that's going to be. It would be much better if all of us made that switch.
Well, that's a German thing. Germany, just to remind everybody, they make Mercedes-Benz and Porsche and Volvo, and you Americans make Chrysler and Chevy. Enough said. If you think America makes the best cars in the world, hopefully you're listening to this at the bar and you've had way too many drinks. And in Germany, all the dental schools have a lab tech. America closed them all down and put in hygienists. Love my hygienist, but I don't know why you close down all the dental laboratories. And in Germany, and remember Germany, those borders always change. It used to be Austria, Switzerland. The part of Switzerland that touches Germany is all Germans, and the part that touches France is all French. But that German thinking over there, the patient pays the lab man separately. And their lab men went to 4 years of college. Some of them become masters, like black belts and 3rd-degree black belts. And there are German lab techs that are 10 times wiser. So then you look at other countries that weren't, United States and Canada or Germany and Europe, and they're the ones in Africa, South America, and Asia where they were comparing the 2 systems. And you'll notice Hong Kong only has 1 dental school, and they have 4 times as many people in the laboratory school as they do in the dental school because they see this huge opportunity. And that's why all of these of our business went to China. I went to see Modern Dental. I love that guy. I think he's one of the greatest guys in the world. I always have a hard time remember his name. What is it? Guan? It starts with a G. Oh my gosh, I have to text my son Ryan on that one. But he said, well, yeah, he says Americans, they would talk to labs like in South Dakota, and they would run an ad that says, I need a porcelain stack or a dye trim or whatever. They would run the ad in the newspaper every day for a year and say, okay, I've already lost $4,000 running an ad, so I'm just going to start mailing it to China. And it was just it shows you how policies affect jobs. And when you don't train kids in high school how to weld or fix toilets or electricians or make crown and bridge, it really hurts industry. But I got to ask you one thing, and I hope you don't think this is too sensitive to ask. We're way over an hour, so I can cut off. But back to the girl thing. You were just saying that the girl wanted a longer implant because it would push her lip out, which is kind of like it'd save her money on Botox and fillers. But when you go to Asia, when I lecture in Cambodia, Vietnam, Malaysia, those girls, the most beautiful girls in the world, they will put their finger to their nose or their chin, and if their lip touches their chin, their lip's too big, and they'll go to the dentist, pull the upper two bicuspids, and pull the teeth back because they do not want their lip to touch the line between their nose and their chin. So what is the girl thing? Why would girls in Beverly Hills want fillers and bigger, puffier lips? And in Cambodia and Vietnam and Malaysia, that would just be the wrongest thing. That'd be like coming to Beverly Hills and say, you should gain 50 pounds. You'd look so much better obese. Where does that come from? Is that just cultural preference?
No, I think, well, she was a little more senior. So I think it has to do with the age of the patient. So at a certain point, when women are losing a little bit of collagen from their faces, they would like things puffed out a little bit more and easier just to fill in rather than having little lines around their mouth. They would just rather than filling it with filler, Juvederm, they would rather have their lips support their teeth support their lip more so that they don't want to have those little lines.
I got a much better way. What I do is I just turn out the light. You know what I mean? If you go out to a fancy dinner, just say I want to sit in the corner where there's no light, and if there is light, just unscrew it. Just lowering the light.
It's sunny. It's sunny here in California. What if they're outside?
My last question. I know we're on double, triple overtime, but I have a list of questions that I know they want me to ask a prosthodontist. When do you have to take a bite, and how do you take a bite?
Oh, okay. So I take a bite almost all the time. And just like I adjust occlusion almost all the time, just like I have articulating paper and shim stock on my counter all the time or on my tray almost all the time. And so if you're taking a bite, like you're making a triple tray impression, I had to do a triple tray impression for my 3/4 crown today, right this morning. And the patient bit down on the triple tray, and I don't think that she bit down properly. It just doesn't look proper. And sure enough, I took a triple tray impression out, and she was biting on the tray. So that means the bite is going to be off. It's going to be distorted. So right away, I made a bite. In that situation, I just injected PVS material and just had her bite down. And then the lab, that's going to be adequate for that. They're going to pour the model in the triple tray, but not utilize that occlusion. And I think this could be something that is common among general restorative dentists. They can just shave off that part where the patient obviously bit on the tray, which she has her third molars in. So that's why this happened. And very tight cheeks, very difficult to retract and difficult to insert the triple tray. If it was something, if I'm doing a full arch restoration or a reconstruction, again, I always make sure that before I go to finalizing the preps and final impression, I want to make sure I have a solid occlusion. So every time the patient closes up and down, my centric occlusion or CR is going to be stable. And I also look at it and I want to make sure I'm going to have a tripod. So I have occlusal contact left side, right side, and somewhere in the anterior. If I have something stable like that, I can use pretty well anything to make that bite registration. I can use the PVS material. I used to use AlliWax and things like that. It's been a long time since I've done that. I'll probably use more of a PVS material. But I'm never going to I'm not going to have a full arch of upper preps. I think we did this in grad school. I'm just not doing that anymore. And we did a full arch of upper preps, full arch of lower preps, and you had things articulated, and you already had the incisal guide table made. But it's just so much easier to make sure you have a left contact, a right contact, and anterior contact, so you have a tripod. And you know that you can replicate that. Or there's sometimes I've actually restored, let's say I've restored the anteriors and I've restored premolars, but I've kept my molars where I haven't done the final impression yet. Or I might do the anteriors and I might do left side posteriors and keep my right side in provisionals. So that's my occlusal vertical stop, because then that way I can do a triple tray and I can retain the vertical stop. Let's say I have the right side posteriors, I have a second molar on the left side, and then maybe the canine over on the left side. So I try and make sure I always have a tripodized situation, and I cross mount my models on the articulator, my diagnostic cast. I cross mount my master cast with diagnostic cast of my provisionals whenever I'm doing a reconstruction case. Does that help?
I could talk to you for 40 days and 40 nights. Her name is Dr. Careen Wei-Young, and her middle name Wei, W-A-I, is in Chinese, stands for wisdom, correct?
Yes.
And you have been full of wisdom for this entire podcast. In fact, we should call it the Wisdom Podcast. We should work Wei into the title. Her middle name is Wei, and that's Chinese for wisdom. And you are a very wisdom-filled prosthodontist in Beverly Hills, California. And it was just a supreme honor that you would come on the show and talk to my homies, not just for the hour you promised, but you almost went 2 hours. And thank you so much for all that you've done for your patients in Beverly Hills and all the dental societies. But thank you so much for coming on the show. And hopefully someday you'll grace Dental Town with a article in the magazine or online CE. We have 400 online CE courses. They've been viewed over 1 million times.
Let's do it.
Well, I would love to. It'd just be an honor to have you grace our media company with your wisdom. Wisdom Way. Careen, thank you so much for coming on the show today.
Thank you so much, Dr. Farran, for having me. It's been my pleasure.
All right. Have a great day. By the way, my middle name, Eugene, is Irish for drunk. That's a little different, but have a great evening.
Thank you, too. It's been an honor.